Next up is Dr. Jane Lougheed and Dr. Sherri Katz. Dr. Lougheed is Chief Pediatric Cardiology at the Children's Hospital of Eastern Ontario in Ottawa. She's an associate professor in the Department of Pediatrics at the University of Ottawa, and she has a large clinical practice, including general pediatric cardiology with specialty clinics in fetal cardiology, neuromuscular disorders, and heart failure. Her research interests include fetal cardiac outcomes, physical activity in congenital heart disease, and the genetic basis of congenital heart disease. Dr. Katz has worked as a pediatric respirologist and clinician investigator at CHEO since September of 2003. She's appointed as a senior scientist at CHEO Research Institute in 2017 and has served as the division head of pediatric respirology at CHEO since 2018. Dr. Katz also holds an appointment as full professor of medicine at the University of Ottawa and is cross-appointed at their School of Epidemiology, Public Health, and Preventative Medicine. We also have Dr. Derek Wong, Program Director for the Royal College of Physicians and Surgeons of Canada, who will be on our panel. And the topic we're going to be looking at for the first part of the afternoon is all things heart and lungs. I'd like to welcome our speakers and to the stage, please. So you want to come on up, that'd be great. Warm welcome. And I'll pass it over. Thank you very much.
Hello, everyone. I'm absolutely delighted to be here speaking with you today. The last time I was at a DMD Family Forum, I think was almost a decade ago, and I'm happy to share that there's new information about the respiratory aspects of neuromuscular disease. This is an area that I've been interested in really throughout my career, and I really have to express my sincere gratitude to all the patients and children and families that I've learned from over time, but also to the organization, because a decade ago when I came to speak to you, we were trying to secure funding to do a national randomized controlled trial of lung volume recruitment therapy to help the lungs in individuals with Duchenne muscular dystrophy. And you were kind enough to fund the work, which has created a national, really a group of interested respirologists who have stayed together, even though the study is now done, and I'll share the results with you. But it has set the stage to be able to do more, to explore new respiratory therapies and to help over time. So over the next few minutes, my goal is really to describe to you the respiratory complications that can arise in neuromuscular disease. And specifically, we're going to focus on an impaired cough and sleep disordered breathing. And we'll also review some of the non-invasive respiratory management strategies, which are going to include infection prevention, airway clearance, and non-invasive ventilation. So first, a bit of background. Why do people with DMD develop respiratory problems? And really, there are two challenges. The respiratory muscles are weak, which affects ability to take a deep breath and causes chest wall restriction and can result in nocturnal hypoventilation or underbreathing during sleep at night. And the second is that you need strong respiratory muscles in order to cough effectively, which helps you to clear secretions and mucus from the lungs. And if that isn't the case, then you can retain secretions, which sets one up for chest infections and atelectasis, which is an area of the lung that's not as well expanded. The basics of respiratory management are really being proactive, recognizing problems and managing them early. Anticipatory guidance, so planning for things that may be stressors on the respiratory system goes a long way to not running into trouble. Preventing infections wherever possible, clearing the airway of the mucus, supporting breathing at night with non-invasive ventilation are the things that really are the mainstays of treatment. So first, let's talk about impaired cough. In order to cough effectively, you need to be able to do four things. You need to be able to get a big breath in. You need to close your voice box, your glottis. You need to generate pressure in the lungs, and then you need to release it expulsively so all the mucus comes flying out. In individuals who have either weakness of the muscles that help them take a breath in, they may not get enough force to expel the secretions. And over time, if you're not taking deep breaths all the time, then the range of motion of your chest wall becomes limited as well. Much like any other joint, if you're not putting it through exercises that stretch it, it becomes a little bit stiffer. The lungs themselves are actually quite healthy, but if they're not well expanded, then they become stiffer and it becomes harder for gas exchange to occur. So how do we assess the cough? And there are a few things that we ask about in clinic that are quite helpful. And for people in the room, I think it's important to know signs that we're looking for of when the cough may not be as strong. So one of the things is that many people can cough quite effectively when they're healthy. As soon as they get a cold and they have lots more mucus, it's suddenly that much harder to keep up with the cough and to cough as much as they need to. So asking for me about how an individual handles a cold is often the most telling thing to figure out if they're doing well or if they're going to need support at times when they're going to be sick. How long the colds last. Does that cough linger forever and the chest sounds rattly for weeks on end? Have there been episodes of pneumonia or chest infections that need antibiotics? And has the person been hospitalized because of a respiratory illness? When I'm examining somebody in the clinic, I'm looking at their range of motion of their chest wall, how much their chest moves when they take a big breath, their breathing pattern, and how much work they seem to be doing to breathe. And for some people, if they can't take deep breaths, they compensate by breathing shallowly and breathing fast. So that's sometimes an indicator for me as well. And the other thing I'll often ask people to do is to cough for me as hard as they can. And you can get a pretty quick sense of whether that cough is going to be effective in clearing secretions. There's some measures that we can do in a pulmonary function lab that are more objective measures of lung function and are things that we can use to track changes over time. These are typically started when somebody's around 6 years of age. It takes a fair bit of coordination to do a PFT, not the easiest thing to do for anyone. And the measures that we get really look at lung volumes as well as the flow of air from the lungs. So the one that most people are probably familiar with is, is the forced vital capacity. That's the measure of how much air you're able to get in and out of your lungs when you take a normal breath. And it's expressed as a value that's called a percent predicted. So if we know what is normal for healthy people of a certain sex and height, then we can figure out relative to that population whether somebody's forced vital capacity is increased, decreased, or normal. And it can be tracked over time. We know that lung function changes over time. That forced vital capacity, if we measure it as a volume, actually increases early in life and then plateaus and then starts to decrease again. But if we know what that change should be, then it helps us to know if things are going awry. The other measures that are more specific for respiratory muscle function are called the MIP and the MAP. This refers to the maximal inspiratory pressure and the maximal expiratory pressure. These are done by having somebody breathe in as hard as they can against a resistance or out. And it's a measure of the pressure that's generated. That one's a little bit more effort dependent, but it's more specific to the respiratory muscles. What is sort of newer is this notion of cough peak flow. So this is if you have somebody cough into a device that measures the amount of airflow they generate, that's a measure of cough strength. That cough peak flow number has actually become quite popular in clinical care guidelines because thresholds have been identified for when one would expect that a cough would be sufficiently weak that somebody would have trouble clearing the mucus from the lungs during infections, and or when they would have a weak enough cough, they might need some assisted therapy on a regular basis. Their norms for kids, their thresholds really that are reported as a single number for individuals 12 and over. For younger children, it's a moving target as they grow and get stronger and older. And the last number that or value that I'll point out to you, because I'll mention it again later, is called the maximal insufflation capacity. What this refers to is with the assistance of a device that helps you get a deeper breath in, how much air can you get into the lungs with assistance at the end of a deep breath in, the maximum insufflation capacity. So we can measure it. we can identify when somebody's getting into trouble. What do we do about it? So the first thing is to try to prevent any infections that we can. And I think as much as I would love to tell you that's a realistic goal entirely, it's probably not. We all know that everyone gets colds and other infections through the course of every viral season. But in preventing with pneumococcal vaccination, RSV vaccination that's available for children under the age of 2 years, a flu shot, and now COVID vaccination helps to avoid some of the common respiratory infections that somebody might get hit hard with. And then the other type of treatment is something called lung volume recruitment or airway clearance, which we'll focus on a little bit now. So the principle behind this is kind of like blowing up the tire with a bicycle pump. And the idea is that if somebody's able to take a certain deep enough breath or not deep enough breath on their own. So this is the amount of air that somebody can get in and out of the lungs with their own breathing. And we asked them to take the biggest breath that they could. And then we had them push more air into their lungs. So we give them a breath and ask them to hold it, and another breath and ask them to hold it, and another one, so that we're stacking breaths one on top of another to really inflate the lungs to that maximum insufflation capacity, the most air that can be held in the lungs. Then what that does, remember I told you the first step to cough effectively is you need that big breath, and it also helps the lungs to recoil back because your chest wall naturally coils inward with the muscles, and helps you to get a more forceful expiration, which means a more forceful cough. And you can accomplish this with 2 types of devices, one low tech and one a little bit fancier. So the first is the self-inflating ambu bag with a one-way valve. This looks it is a resuscitation bag, but it has a one-way valve in it. It needs to be clearly labeled. This is not to be used in a resuscitation, and we don't want somebody to grab it in an emergency. But the nice thing about it requires the cooperation of somebody else to help to provide that breath. So they're squeezing the bag, which is attached to a hose and a little mask or a mouthpiece that helps to push air into the lungs. What you can do is by looking at the person that you're doing it with, you can get a quick sense of this is comfortable or, oh, I don't like that. You watch people's eyes bulge and you kind of go, oh, okay, we filled the lungs enough. But you get direct feedback and you know how much air and pressure to deliver. It's an inexpensive device that really is about $25. It can be nice and portable, doesn't require a power source, and it's readily available in Canada. The fancier device is the inaxiflator, often referred to as a cough assist device. In this one, the individual who's receiving the therapy doesn't need to cooperate in the sense that they don't actually need to breathe in exactly, although we try to time it, exactly at the same time. They don't need to hold their breath in between, and the positive pressure to inflate the lungs is delivered more continually. And this is a more expensive device, although there are funding programs that support it throughout, certainly in Ontario and in other provinces as well. But it's a little bit more cumbersome, although they're getting smaller. They do require a power source as well, so a little bit less portable of a device. So why would we use this? It improves cough efficacy, helps somebody cough more strongly, clears out more secretions from the lungs. That act of expanding the lungs regularly helps to maintain that stretchability of the chest wall and the range of motion of the muscles of the chest. It maintains the lungs' compliance or elasticity. So one of the things that causes lung function to decrease is if the lung isn't well expanded. And by keeping it well expanded, you avoid some of that, we hope, which would slow the progression of restrictive lung impairment, and it helps with the airway clearance of secretions. Nothing's without complications, but I will tell you that this type of therapy has been used for 20 years and more with very, very few complications. So the one that we worry about and the one that we watch for is that much like a balloon, if you overinflate it, something can go pop. You can end up with air leaking around the lungs. That thankfully is exceedingly rare. The pressures are adjusted and titrated so that we don't get to huge pressures and hopefully don't cause that to happen. There aren't really any reports in children of pneumothorax, that air leak happening. In adults, they're very rare case reports, and it's typically in individuals who had another predisposition, something else about their lungs that made them more likely to develop this complication. So what is the evidence that it works? So one of the challenges with lung volume recruitment is that it's often introduced at the same time as other therapies. So it makes it a little bit difficult to tease out the specific effect of that alone. But when implemented as part of clinical care, we know that it can decrease hospitalizations, episodes of pneumonia or chest infection, respiratory failure, and even the need for a tracheostomy. In our own research, we looked at the difference between the amount of air somebody could get in their lungs on their own, the vital capacity, and the maximal insufflation capacity. That's with assistance, how much air you can get into the lungs, which is a measure really of how stretchable the chest wall is. And what we found is that, see if I can get this pointer to work, is that this is the MIC over time, which is obviously higher than somebody's spontaneous vital capacity, but over several years, you can maintain that stretchability of the chest wall. So it is effective in that regard. And cough strength, getting that cough peak flow, that measure of cough strength over the threshold when we think cough is going to be effective, with assistance, can be maintained for up to 8 years if you use lung volume recruitment therapy regularly. In individuals with very low lung function, if you introduce this as a regular therapy, as part of their regular exercises, if you will, twice a day, over time, you can really slow the rate of decline of lung function. So this is individuals with very advanced lung disease, a very small group of them, and looking backwards in time, which is never quite as perfect as looking forwards in time when you're doing research. But the difference is dramatic. So this is the rate of decline of forced vital capacity, that most important measure, in the 2 years before lung volume recruitment was introduced and in the 2 years after. So there's a 90% reduction in the rate of decline in lung function after starting to use this therapy regularly. So we know it works in individuals with more advanced lung disease. One of the challenges, though, is knowing when is the right time to do this? How much do you need to do it? Is it helpful for somebody who's much younger and whose lungs are healthier? And so this was where Jesse's journey came into play and where this big research project came into play as well, because we wanted to conduct a really robust study to try and understand whether lung volume recruitment exercises were going to be helpful for children with Duchenne muscular dystrophy. And we called this the STEADFAST study. Stacking exercises, so that lung volume recruitment, attenuate decline in FVC and sick time. The goal of the study was to determine whether these twice daily lung volume recruitment exercises, and for this one we used the low-tech version with the ambi bag and the one-way valve, in addition to standard of care, does it reduce the rate of pulmonary function decline compared to the current standard treatment? So we designed this as a multi-center, single-blind, parallel randomized control trial. That means that half of the individuals in the study received the therapy, half of them received usual care, and we compared over time their rate of decline. The study was carried out at 9 pediatric centers across Canada and included boys between 6 and 16 years of age. We included individuals who had less severe respiratory impairment and that their forced vital capacity was at least 30% predicted, and they weren't already receiving lung volume recruitment regularly. So the intervention was that they did this therapy twice a day compared to usual care, and we went to see what our results would be. So what we found, it was a relatively healthy population at baseline from a lung function perspective. But half of the individuals actually had normal lung function who were enrolled in the study, and their median age was 11 and a half years of age. About a third of them were using wheelchairs at the time. So what we found is the adjusted mean difference between the groups at 2 years was 1.9% predicted. So that's a pretty small difference in lung function in the direction of treatment benefit. So it probably helps, but teeny tiny bit. And really, statistically, it was hard. We couldn't say that there was a difference between the two groups. So I don't want you to come away from this thinking that I don't believe in the lung volume recruitment therapy. I absolutely do. I just think we haven't yet come up with the right timing to figure out when this therapy should be introduced and how it should be used. And what we learned from the study is that there's obviously a burden associated with this when we're asking people to do this twice a day, and that when you have relatively healthy lungs, this is a tool you can pull out of your toolbox when somebody's sick, but it may not be something that needs to be done every single day on a regular basis, and we still need to learn more. There are a huge number of children and families that participated in this from across the country, and lots of co-investigators, many of whom are in the room. And so lots of people to thank for this work, and it's the beginning. So I'm going to shift a little bit now and talk about nocturnal hypoventilation, which is the other challenge that can arise in individuals with neuromuscular disease. And what that really refers to is that in all of us, we breathe more shallowly when we're sleeping than we do when we're awake. And as muscle weakness progresses, the breathing can become too shallow to allow oxygenation and for carbon dioxide to be breathed out. And having scoliosis or having obesity are factors that make that hypoventilation risk higher. We know that the prevalence is high in individuals with neuromuscular disease if we look for sleep disordered breathing. And the more we look, the more we're likely to find it. But identifying it is challenging. The warning signs that go along with it are quite vague. And to be honest, they're sometimes attributable to other facets of the disease and not related to sleep problems. So the big red flag for me is if somebody's having headaches in the morning. That is sometimes an indication of carbon dioxide levels being high in the morning. The other things that can arise are poor growth, a fear of going to sleep, or not being a morning person, but that's every teenager in the world. So it makes it hard to identify whether it's related to hypoventilation or not. And in truth, most people, because this comes on gradually, are quite asymptomatic. It's often after we correct the problem and provide them respiratory support at night that they kind of go, wow, I really wasn't sleeping so well. Now I feel so much better. I have more energy and I feel better. People have tried to use clinical markers like pulmonary function tests to identify when the onset of hypoventilation occurs. I'll tell you, they're not perfect measures. There's no clear cutoff where this begins. And screening is probably necessary when somebody's forced vital capacity goes somewhere in the vicinity below 60%, maybe even before then. Blood gases or blood tests that measure carbon dioxide can sometimes be used, but daytime elevated carbon dioxide on a blood test is actually a late finding. So not a very sensitive measure to identify when hypoventilation starts. Our best test is a polysomnography or a sleep study. This is really the gold standard, and it's the only technique that allows you to comprehensively measure everything that's going on in terms of sleep quality, because it measures the sleep stages that somebody's in, their breathing pattern, their oxygen level, their carbon dioxide. But it does require an overnight stay in, as you can see, not the most beautiful of accommodations, with a bunch of stickers and wires in a bed and environment that's not familiar. So it's not perfect either, but it is still the best we've got. If we identify nocturnal hypoventilation or sleep disordered breathing, the treatment that we recommend is non-invasive positive pressure ventilation. And what that really is a box that takes air from the room through a hose into a mask and blows air in under pressure. It blows an amount or pressure of air up to an amount that we set for the end of inspiration, and it keeps a certain amount of pressure so that when you breathe out, it still maintains the airways open and prevents the lungs from collapsing. We can also set what's called a backup rate to ensure that somebody receives a certain number of breaths per minute if they're not doing it on their own. The benefits, we know that if you're sick acutely, if you end up in a hospital, that this can sometimes prevent a need to go to intensive care unit. It can improve gas exchange. It can decrease the number of hospitalizations and infections and the amount of time in hospital for respiratory infections. It has been shown to reduce the number of physician visits, the number of courses of antibiotics by preventing pneumonia. And even though we might expect somebody to have weaker respiratory muscles and more difficulties with respiratory infections, it's actually been shown that if you start non-invasive ventilation in the years that follow, you may get less admissions to hospital. So how do you know when to start? And the decision is really based on identification of a nocturnal hypoventilation or respiratory dysfunction at night, the presence of that nocturnal hypoventilation, Sometimes if somebody's getting recurrent chest infections that are landing them in the hospital and we don't think they're able to keep their airways open well enough to allow the mucus to escape and keep the lungs expanded, that may be an indication to start the support at night. And certainly if there's evidence of a high carbon dioxide level during the daytime. It's a relatively well-tolerated therapy, does take some getting used to, feels a little like sticking your head out of a car window when it's going by. There's a lot of air rushing, but with time, most people do acclimatize well and feel better with it. The things that we watch for are irritation on the bridge of the nose, because that's where the mask sits and it can irritate. We worry a little bit that some of the air that is breathed in is actually going to be swallowed and could distend the stomach. So we don't want somebody to have reflux or to aspirate stomach contents. We, for that reason, recommend not applying it immediately after a meal. Trying, if you have a feeding tube, to vent the feeding tube to let air escape from the stomach, and to make sure that any reflux is well treated. And then, of course, like anything that's expanding the lungs, there's that risk again of pneumothorax, which is really quite small. We know we're doing well with the therapy when somebody feels comfortable when they use it. If it feels good, you use it. If it doesn't do anything for you, you're not going to stick with it. We can measure gas exchange improvements in the sleep lab or other environments. And really, it's how well people feel, whether it's making them have less events with respiratory infections and improving their quality of life. And this therapy has actually been shown quite well to extend longevity for individuals with neuromuscular disease. If you look to the clinical care guidelines from around the world, the Canadian Thoracic Society, British Thoracic Society, the NIH in the US, and CHEST in the US all recommend non-invasive ventilation for nocturnal respiratory dysfunction. They all agree that polysomnography is the preferred diagnostic test, but it's not always available and wait lists are very long to get this test done. And for that reason, in part, we need to be really proactive with screening. Certainly if there are any symptoms that could be consistent with nocturnal respiratory dysfunction, or if there are big changes in lung function, that should be an indicator to look into it. So I'll leave you with a few thoughts. I think we have a lot that we can offer from a respiratory support perspective to help individuals with Duchenne muscular dystrophy, with prevention with vaccinations, making sure the lungs are free of secretions with lung volume recruitment and airway clearance will really help prevent respiratory problems. They may help to maintain lung function as well. And non-invasive ventilation is really the mainstay of any support for somebody who has breathing problems at night. And I know there's lots on the horizon that I think is going to be quite game-changing in terms of the trajectory for people with Duchenne muscular dystrophy, but you need healthy lungs to be able to take advantage of it. So I think keeping that in mind is important. I think I'll stop there.
Thank you very much, Dr. Katz. I guess in the interest of time, can we have Dr. Lougheed give her talk, and then we'll do our questions to both of the panelists at the end of the talk. So thank you very much, Dr. Katz.
Just make sure I figured out how to work all of this. Okay. Perfect. So thank you very much to the organizers for allowing me to speak today. I'm a pediatric cardiologist at CHEO and have been following a number of patients with neuromuscular disorders for the last 2 decades. And I see a few familiar faces in the room, so that's always nice to see. So I'm going to try in the next sort of 20 minutes to talk briefly, about the heart and muscular dystrophy. There's lots to talk about, but we'll try and keep this controlled. So the objectives for me will be, I really want to review some of the cardiac issues that can arise in both Duchenne and Becker muscular dystrophy, including the types of things we see, the timing and the presentation of these issues. I want to talk about how we monitor the heart, talk about current and future treatment strategies, talk about prevention. I want to quickly review what cardiac care looks like for a patient throughout the age spectrum, and then also review recommendations for female carriers of the dystrophies. So it's helpful to understand some of the terminology we may use when we're talking about the heart. It's important that the clinician, parent, patient are speaking and understanding the same language. So I have a picture of a heart here. I've labeled the right and left ventricles. Those are the pumping chambers. The right ventricle pumps to the lungs, the left ventricle pumps to the body. So when we're talking about ventricular function, that's what we're talking about. When we talk about function, we're talking mainly about the squeezing of the heart muscle. There's also a relaxing component of function, but the squeezing portion is probably the more critical part of function in muscular dystrophy. When we talk about fibrosis, we're talking about scar tissue in the heart. We talk about arrhythmias. Those are rhythm or electrical issues causing an abnormal or irregular heart rate. Heart failure is when our heart pump is not working as well, when it's weakening. And there's a spectrum of moderate, mild, moderate, and severe heart failure. And then a number that you'll hear in the clinic is ejection fraction. And that's one of our measures of heart function. It's referred to in a lot of the literature. And normal heart function should be an ejection fraction of over 55%. So if we look at the cardiac involvement seen in muscular dystrophy, the abnormalities of heart function are the most prominent. So the main abnormality involves the systolic or squeezing function of the heart. And as I said before, there's also a relaxing component of heart function, and that can also deteriorate as you get scar tissue in the heart. So the heart has to squeeze, but it also has to relax and fill. Less common in muscular dystrophy or in Duchenne and Becker muscular dystrophy are heart rhythm problems, but they can occur. And those are problems with the electrical system. And so we can have different types of heart problems. We can have fast but normal rhythm, which is we call sinus tachycardia. We see that in a lot of boys with muscular dystrophy. And we may or may not have a reason to treat that because it's actually the normal rhythm, just a little faster than normal. But we also see fast and abnormal rhythms, things like ventricular tachycardia, atrial fibrillation, atrial flutter. And we see slow rhythms a little less commonly, but that's where we see heart block or the heart, the top and bottom part of the heart not talking to each other properly. When we look at the heart, we know the heart's a muscle, but heart muscle is different from skeletal muscle. And the heart muscle in Duchenne muscular dystrophy does change at a different rate and stage compared to the skeletal muscle. But what we do see happening in muscular dystrophy hearts is that the healthy muscle gets replaced with scarred muscle. I'm just trying to make the pointer work here. And so this is a pathological picture of a heart, and this white sort of tissue coming into the healthy muscle is kind of this orangey pinky color, and there's scar tissue coming into the muscle. And then this is a picture where we've taken a microscope slide of a thin slice of heart muscle, and this blue shouldn't be there. It's fibrosis or scar tissue entering into the heart muscle. And so that's what we see when we look at the heart in muscular dystrophy and what's causing the problem. So this replacement of healthy muscle with scar results in the muscle not working as well. So not squeezing as well, not relaxing as well, and also can trigger heart rhythm problems because the muscle cells in the heart are also electrical cells. They all have the potential to be electrical cells as well. So they're sort of multifunction cells. Now, if we look at the obvious changes in heart function, the ejection fraction in children with muscular dystrophy, we see that the percentage of boys with decreased heart function increases as they get older. So if we look in broad categories, age 5 to 10, we see the minority of boys will have changes in their heart function. As we move into the teenage, early teen years, preteen years, we start seeing that number increase. And then once we get over age 20, we see heart changes in the vast majority of people with muscular dystrophy. So there has been a changing approach to management and follow-up and management of patients with muscular dystrophy over the last few decades. We started off with not having much to offer, and so having to accept natural history and say, okay, we know that the heart is going to change. We have to accept that. There's nothing we can do about it, and we just have to be aware of that. We then had the other end of the spectrum where we said, okay, well, once the heart is failing, well, we have treatments for that. So let's focus on that. And now we sort of have this changing approach where we're looking now at sort of modifying or preventative strategies to maybe prevent, or maybe not completely prevent, but at least delay the progression towards the third heart, where we're starting to manage heart failure. So that starts with us regularly assessing the heart, and what the recommendations suggest is that regular cardiology assessment happen in the pediatric age group with a pediatric cardiologist, in the adult age group with an adult cardiologist, but someone who ideally has neuromuscular disease expertise. Especially in the adult world, heart failure management is very different depending on the cause of in terms of when you intervene, what you intervene with is different depending on the cause. For example, if you have a heart attack from coronary artery disease, how you manage that sort of patient with heart failure is going to be very different from someone who has neuromuscular disease. Regardless of age, we would recommend a cardiology assessment at diagnosis. And it's really, in a 3-year-old, we're not going to do anything other than some basic investigations, but it sets the stage for this need for ongoing follow-up. We recommend at least annual follow-up after age 10. And the follow-up includes clinical evaluation and testing. In the past, it was mainly testing, but the clinical evaluation piece and the discussion piece about what investigations are appropriate, if there are any medications we'd recommend, is actually very important. We have extra visits scheduled for symptoms or pre-anesthetic or surgery, and we'll talk a little bit about that. There's minimal clinical use for blood work. There are some blood tests like troponin and BNP that people may read about in the literature. There's not a lot of use for blood work on regular monitoring at this point. Not a lot of data to support that. So what does cardiology testing look like? Well, anyone who has a child with muscular dystrophy has probably been through a lot of these tests. We start with ECGs. These are electrical tests where we put stickers on the chest and assess the cardiac electrical activity. It also gives us an assessment of the heart muscle size and sometimes a little bit of a hint as to heart muscle function. The problem is a lot of children will have very abnormal ECGs that don't necessarily correlate with their echo or their other test findings. But it is still a baseline test that we will do routinely. Low risk, it takes about 5 minutes. Sometimes we add a Holter monitor, and this is where we put a little monitor on with the same sort of sticker ECG leads, and it records the heart rhythm over a period of 24, sometimes longer, hours. And this is for looking for heart rate and rhythm abnormalities. So we usually only do it when we have a suspicion that there may be an abnormality with that. A lot of the boys really don't like this test because it's uncomfortable to wear for 24 hours, but it can be very useful in those patients where we're trying to sort out, is there an electrical problem going on, which is actually the minority of patients. The main test that's done every single year is an echocardiogram, and any boy with muscular dystrophy gets used to having lots of these tests. And this is where we use ultrasound beams to image the heart structures, measure heart function, and assess blood flow in the heart. Echo can be limited by people who can't lie flat. If you get short of breath, lying flat can be hard. If you have scoliosis, it can be difficult. And if you have increased body fat, it does make it a little bit more challenging sometimes to get those pictures. And so we see that imaging does become a little more challenging at adult sizes or with you have increased BMI or increased weight. These are just a couple of pictures to sort of demonstrate one of the aspects we're looking at on echo. On the left side of the screen, we have a heart that's showing normal function. We can see it's squeezing very vigorously, becoming about half the size of when it's in its biggest to its smallest. And on the right-hand side of the screen, I've got an example of a heart with decreased function where it's just not having the same level of squeeze. And that's sort of one of the classic things we're looking for on an echocardiogram. But on this next slide, I've got some examples. Those last pictures were of perfect windows. These are pictures that are more reflecting the reality, that sometimes it gets really hard to see how well the heart's squeezing and to get our measurements that we rely on to be able to generate a lot of the numbers that we talk about. And so sometimes when we have windows like this, we have to just have a gestalt that, okay, the function looks okay, but I can't actually assign a true number to it because I just can't get the picture well enough to see that. So other tests that we will use, one that we try to use as the children get a little bit older is a cardiac MRI or magnetic resonance imaging. This is just a picture of a typical MRI machine. It gives us nice three-dimensional imaging of the heart. Does not involve radiation, but it is a little bit technically sometimes a bit challenging for the kids to tolerate. It does give us great assessment of function. It also shows us the scar tissue in the heart really well, and that's very, very helpful. But if you have trouble lying flat, if you're claustrophobic, if you have a bit of trouble cooperating, we can sometimes have some challenges getting MRIs done. But it is a very, very, very helpful test, and it's now sort of part of guidelines to be doing regular MRIs in the adolescence age group. It does involve an intravenous as well, and so we always try to be very clear because some people are very needle phobic, and it's important that people understand that it will probably most likely involve adding an intravenous as well. Sometimes what it does give us though is these are some beautiful pictures showing on the left-hand side of the screen normal heart function, on the right side of the screen a heart that's maybe not quite as good function, but what it does give us these beautiful pictures. And so even if you've got a very challenging body size for echo images, MRI usually can get past that, and the only thing that really interferes the most with MRI is if you've got metal things in your chest. So we can get beautiful images that can give us really accurate ejection fractions. The other thing it can give us is the picture at the bottom shows us a little bit of white collecting. I'll try and show it here with the pointer in the walls of the muscle here. And this is late gadolinium enhancement, which actually demonstrates scar tissue to us. So we'll sometimes see scar tissue before we see the function abnormalities. And that's becoming an important clue when we talk about prevention of heart issues. Now, the symptoms of cardiac changes are challenging because just like Dr. Katz said, a lot of these symptoms go along with some of the other health challenges that muscular dystrophy patients have. So generalized fatigue, shortness of breath, swelling of the feet and ankles. Some of these things happen and they're not related to the heart, but we have to be aware that some of these can be the symptoms of cardiac changes. The reality is that and what we've learned over the years is that we have to be proactive looking for the cardiac changes on testing, because most of the boys, when they start getting cardiac changes, are non-ambulatory. They will often have some of these side effects of other therapies, or it's very hard to assess. A lot of the adult heart failure guidelines are based on dyspnea on exertion, meaning when you walk, how short of breath do you get? Well, we can't use any of those guidelines in the vast majority of our muscular dystrophy patients. So we have to be on the lookout and be a little bit more proactive than waiting for someone to come in with symptoms. Because if we wait for people to come in with symptoms, we're going to miss lots of poor heart function, miss a lot of opportunities to sorry, I'm getting a 5-minute warning. Okay, I'll try. All right, so how can we treat the heart? So there are lots of heart function treatments, and I'm not going to go through them all other than to sort of list them here. But the goals of treatment of heart function is that once the heart function starts to change, that's when we start to treat it. And so the point of treating heart function or heart failure is to alleviate symptoms, slow the progression, prolong survival. And there are different choices for medications. We usually start with something called an ACE inhibitor, perindopril sort of being one that people may be familiar with. We have beta blockers, which slow the heartbeat down, block the effect of adrenaline on the heart. And we have aldosterone antagonists, sort of our spironolactone or eplerenone is sort of our main sort of 3 drugs that we will use when we start someone on therapy for heart failure. So this is someone who already has heart function changes. There are advanced heart failure therapies that are on the horizon, may become possibilities for some children or young adults with end-stage heart failure and muscular dystrophy, ventricular assist devices, heart transplant, limited experience, very strict selection criteria. But the thought of putting in a ventricular assist device is something in a person who has otherwise good bodily function, maybe isn't a transplant candidate, but this can maybe alleviate some symptoms by putting a pump attached to the heart. That may be an option in certain clinical situations. I want to talk a little bit about preventative therapies, because what we do know is that cardiac fibrosis happens early and often before we see the heart function changes. So is there anything we can do to prevent that change in the heart function from happening before we sort of start to see it on our regular testing? If we're talking about preventative strategies, we have to remember that we're talking about things that ideally have lower risk, lower side effects, because we might have to treat a lot of people to get benefit in a few. So we have to talk about safe treatments versus a treatment of a disease where we know we're going to give you an antibiotic to fix this, and most people are going to have a response to it. Lots of prevention studies, very small studies in muscular dystrophy. So it looks like a lot, but each study probably has about 10 or 15 patients in it. So it's very hard to draw very good conclusions. There is a recent meta-analysis in 2022 that sort of summarizes those prevention sort of studies. And what we've sort of concluded is that in most patients, there's benefit to starting an ACE inhibitor, such as perindopril, around age 10 to try and slow the fibrosis and inflammation changes that we see in the heart. And then we have other medications in our pocket, beta blockers if we have increased heart rates that we want to treat. Lots of side effects with beta blockers. We have aldosterone antagonists, spironolactone, for example. When we see MRI changes of scarring, we will sometimes want to start. There's some benefit potentially to starting a medication in that situation. And we know that steroids do help slow heart function changes. I want to mention that there's other preventative measures that are very important. So we want to make sure that other conditions are treated that can change your heart function. So high blood pressure, diabetes, lung function. These are all very important to maintaining heart function for the long term. We want healthy lifestyle, diet, mobility. Mobility isn't just walking, it's also moving your body in other ways. And we also want to make sure that when boys have anesthetics or surgery, that they are optimized. So if there's any heart function abnormalities, we want to treat that before a child goes through a procedure that might be stressful to their heart. This is just a big diagram that came from one of the recent guideline papers, really showing all of the ways in which we have to assess the heart and evaluate the heart in these patients. And I'll just leave that for reference. I want to make a quick word about female carriers sort of at the end of this. Female carriers have about a 10% lifetime risk of developing cardiomyopathy. So it's very important that the carriers are not forgotten in this process, and that may be mothers, maybe sisters. They need a baseline ECG and echo at the diagnosis point of carrier status, and then that needs to be repeated every 3 to 5 years with appropriate therapies, the same therapies that we would be offering in the boys being offered to the female carriers. And cardiac MRI is becoming more of a standard test in our carriers, though there's not a lot of data to really say what the benefit of that is, but it's important that they be included. So I know it's a complex area, but I hope that we've had a little bit of a time to sort of talk about the cardiac issues that we see both in DMD and BMD, why, how, why, when we do our cardiac testing, and a little bit of thought about preventing and treating heart issues and some of the issues about female carrier heart testing. The prevention piece is going to be very important over the next several decades as we have more and more therapies available for these boys that are prolonging life. And if there's anything we can do on our end to really prevent, slow the progression of the cardiac disease, that is really where we need to be focusing at this point.
Dr. Lougheed, do you have any questions from the Huol or the online group first?
Yes, we do. Okay, so from Mark, how does myocarditis affect someone who already has Duchenne?
Good question. And it's sort of become a question, especially with our post-COVID vaccine and COVID infection myocarditis, sort of that's been a lot in the media. So anything that will affect the heart muscle in a detrimental way, and myocarditis, which is inflammation of the heart muscle, has the potential to change heart function, is not a good thing to have in Duchenne muscular dystrophy. So, it's part of the preventative strategy would be to try to avoid any additional stressors on the heart. A lot of myocarditis we can't prevent, but we definitely do see myocarditis happening with COVID infection, with influenza, and so sort of trying to prevent those infections is sort of the only sort of tool we have right now. But it absolutely can be an additive condition. Yeah.
Thank you. Another one from online. Is there any relationship between DMD processes in the body on deflazacort and increased cholesterol and triglycerides level? We have a problem with that. Thank you.
I'm not an expert. That's a little bit out of my area of expertise. So I'd have to defer that question. I mean, certainly it comes into that whole preventative medicine strategy, treating hypercholesterolemia, managing hypertension, for example, because these do have an impact on other types of heart disease that are all part of that preventative category. Yeah.
Perfect. And the last one from online before we get to those in the room. Would you recommend updating to Prevnar 20 in adults with DMD? The immunization history is that Prevnar 13 was done in childhood and pneumococcal 23 every 5 years.
I can take that question. It might be best directed, honestly, to an infectious disease specialist and probably needs an individual discussion. But as a general principle, the more that we can prevent from a respiratory infection perspective, the better. So I think it's a wise question to ask and discuss with your care provider.
Perfect. Thank you.
Anyone in the room? I'll have one quick question to the panelists. Given the advocacy that Defeat Duchenne does on a sort of national level, given limited resources in healthcare currently in the healthcare situation that it is now, in both of your respective fields, where do you think we should put a lot of attention and focus in order to maximize quality of life and longevity over the next 20 to 40 years, because it seems like there's been great strides over 20 to 40 years for some of the boys that are here. And then we sort of reach this sort of steady state level where ventilation and home care has significantly improved their outlook. So for the next 20 to 40 years, where do you think we should focus some of our attention, funding, and lobbyism to help some of these boys with this condition?
I'd say from a heart point of view on prevention, there's a lot of new heart failure medications. It's hard to keep track of all the new heart failure medications coming on the market, but there's a lot of better understanding of the process that's happening in heart muscle before you start to see the overt signs of heart failure. And some of these newer medications attack some of these pathways that are very important in sort of setting the heart up for how it remodels in an abnormal way when the function starts to deteriorate. And so I would foresee, I would hope that we would be able to have some more information from research on how these more novel heart failure medications have a role in prevention. Because once we have heart failure, we're sort of pedaling backwards. We really want to try and prevent. And so I think prevention is really where we need to be focused, because we kind of know how to treat heart failure once it happens, but we want to prevent that or delay that.
I think that's a great question. I think similarly in the lungs, you want to prevent loss of lung function. And I think we have a long way to go to understand the impact of new therapies on the horizon and what that means for lung health. We're still trying to catch up a little and really understand what the impact of current therapies are on lung health and lung health trajectory, because it has changed over time. Steroids, for instance, have made a huge difference in maintenance of lung function and have shifted the timelines for when we expect certain things to happen. But I don't think we really know or have good ways of measuring when things are starting to happen. How do we know when somebody's getting into trouble with hypoventilation? And how do we know when the best timing and approach to start lung volume recruitment and airway clearances? I think they're going to be challenging things to study, because fortunately we've got lots of things happening at the same time. But I think there's a lot of room for research, and it may be important to look through registries, for instance, to try to tackle some of these questions.
Thank you very much. I guess that concludes the session. Thank you, everybody.